Hi, this is Jessica Hansen, and this is my presentation on technology and counseling, more specifically on telemental health. Um, the references for all the information I'm sharing will be on each slide, so what's on the screen should be the reference that I'm citing. The relationship between technology and the helping professions stretches back as far as the development of technology itself. The first computer was invented in 1946, and in the 1950s, people like B.F. Skinner and Norman Crowder began to formulate ideas that laid the groundwork for distance education. This is just something I thought was interesting that I found while I was researching. In the 60s, a computerized reflective listening system was developed to test the limits of what was possible, and this uncovered limitations in the ability of computers to administer therapy. However, the possibilities of today allow us to provide distance counseling in a way which would have been unheard of in the 60s. We can interact with clients over video chatting applications, email, phone, and text. The relatively new availability of functional video chatting opens up more possibilities due to the inclusion of both audio and visual information, which would be lost over other platforms. On this slide, I include more information about ELIZA, which is this reflective listening program, as well as a link to try it out. It's surprising how much it can feel like you're talking to a real person, although I will say she's a little bit rude sometimes. Face-to-face and non-face-to-face counseling differ in some key ways. Different modalities of distance counseling also bring their own strengths and challenges. Some clients even prefer distance counseling to face-to-face, although the inverse is also true according to Remley and Harley. According to Kingsley and Henning, some possible differences are reliance on an internet connection, differences in amount of available sensory information, different comfort levels depending on client and modality, and a need for increased or more targeted security. I will begin by talking about telephone therapy. Kingsley and Henning identify that some studies suggest that teletherapy can be just as effective as in-person counseling, while others suggest this is not the case. Teletherapy can interfere with the development of a therapeutic alliance, which is a key factor in client success. Difficulties unique to telephone counseling include the inability to physically interact with clients, for example, handing a client a tissue, and challenges interpreting silences. Clients may be uncomfortable sharing their feelings with a disembodied voice. In regards to email therapy, Kingsley and Henning said that studies have shown efficacy for email counseling in some cases. The unique challenges of email counseling include the lack of audio or visual cues, reliance on text to communicate. Some of these challenges can be helped by use of textual clues like emoticons, capitalization, and asterisks. However, there's still room for lots of misunderstanding. Some clients also may not have access to the internet, leaving them unable to seek this form of therapy. The third form I'm talking about is video conferencing. Kingsley and Henning also point out that video conferencing has been shown to have similar outcomes to face-to-face therapy. It allows the client and clinicians to see and hear each other at the same time, leaving room for some nonverbal communication and tonal cues. Some important nonverbal cues, for example any movements from the neck to shoulders down, may be missed in video therapy. Interruptions in internet service may cause distressing technical issues or even end the session altogether. Clients may not have access to a working internet or a webcam in order to participate in this form of therapy. For the remainder of my presentation, when I refer to teletherapy, telehealth, telemental health, I'm primarily going to be talking about video conferencing just because that's such a popular form that is coming up during this time. The next thing I'm covering is how to prepare for a telemental health session. This information comes from Luxton, Nelson, and Mayhew. There are many things to consider when preparing for counseling over telehealth. First, a client should be assessed as to their suitability for telehealth services. For example, clients struggling with serious anger management issues and living with vulnerable people may not be a good fit, as a clinician may lose the ability to intervene. Other concerns include domestic violence and child abuse situations. Self-harm is another situation which may be unsafe to manage over telehealth. Once a client has been deemed appropriate for telehealth services and has completed necessary paperwork, a safety plan should be put in place to ensure that appropriate actions have been discussed in the case of an emergency. If the client is unfamiliar with the technology being used, it may be necessary to send them instructions or take time to walk them through steps. When starting a session, clinicians should verify the client's identity. They should verify the client's location in case of an emergency, in which case they need to send help. Finally, they should verify that the client is alone in a room without anyone listening to ensure privacy. This next section will cover some special considerations for telehealth, as described again by Luxton, Nelson, and Mayhew. Clinicians should remember to behave much as they would in office, refraining from rude displays or inappropriate attire. Volume and cameras should be adjusted at the beginning of a session to ensure client and clinicians can hear and see each other clearly. In terms of the clinician's own setup, it should also be ensured that no one else will be wandering into the room or overhearing the conversation. The space should be uncluttered, well lit, and private. The camera should ideally be positioned head-on to improve the line of eye contact with the client. Clinicians can still make use of nonverbal information if video is present, but may need to pay special attention so as to not miss cues. Many of the same legal and ethical considerations involved in face-to-face counseling also apply to telehealth. However, there are additional things to consider when working online. Again, this information comes from Luxton, Nelson, and Mayhew's book. Each state has its own laws regarding distance counseling and whether practitioners can see clients from outside the state. This is generally based on the location of the client, not the practitioner. It is important to be aware of the laws in any state you're practicing. Data privacy is another area of unique concern for telehealth. There's also the matter of ensuring the systems and services clinicians use are HIPAA compliant. There should be unique informed consent documents for telehealth, including emergency planning, limits of confidentiality, and conditions for termination of service. Limitations of telehealth should be discussed with clients before and throughout treatment. According to Remley and Harley, other ethical concerns include lack of human presence, inability to attend to high-context communication styles, determination of fees, and lack of personal warmth. There are plenty of considerations for diverse populations when using telehealth services. Cultural humility is as important in telehealth as it is in face-to-face practice. Telehealth can, for example, make therapy available to clients in rural settings of small towns who may be cautious of privacy due to smaller populations. Clinicians should be aware of the community norms and special considerations in the areas their clients are located, despite the therapy taking place online. Telehealth opens up the possibility for clients to see therapists even when they lack the time and transportation to come into an office. Special consideration should be made of a client's ability and access to use technology. Language and literacy are another factor to consider, especially in regards to informed consent. Translation services are available, and asynchronous meetings are another option for translation. Next, I'll talk a little bit about art therapy and telehealth and some of the research on that. A study as early as 2002 by Colley and Subranik explored the possibility for distance art therapy for traumatic illness through the use of a specially designed program. Counselors in this program found it helpful to limit periods of silence, as they brought discomfort and raised concerns over loss of connection. The study concluded that computer-supported distance art therapy is feasible, and technology has improved quite a bit since then. In Ethical Issues in Art Therapy, Bruce Moon cautions that art therapists should take care with the unique ethical concerns in distance art therapy. He suggests that maintaining confidentiality is nearly impossible when services are conducted online. He suggests that some potential benefits include the ability to access underserved populations. In conclusion, there's a lot to be learned about the implications and applications of telemental health. The current situation is forcing a quick development of the field. Many of the same considerations of face-to-face therapy apply in telemental health, but there are extra concerns to be addressed. I hope I was able to address some of these concerns in my presentation.